Welcome to my presentation. I'm Borbély Ruben, and I'm going to talk about advancing acute pancreatitis management and the role of CT imaging in predicting severity and diagnosis of splanchnic vein thrombosis. I'm a radiologist at Bajcsy-Zsilinszky Hospital, Budapest, and I'm a PhD student at CTM. The vision is to advance the understanding and treatment of acute pancreatitis, and the mission is to enhance the diagnostic and prognostic value of CT imaging. So these are my projects, both centered on acute pancreatitis, and I'm going to start with the first one, which is titled "The Risk of Developing Splanchnic Vein Thrombosis in Acute Pancreatitis Increases 3 days after symptom onset." So splanchnic vein thrombosis is a thrombotic state of the veins of the gastrointestinal system, which includes the portal, mesenteric, and splenic veins. It has wide-ranging etiologies, but in AP specifically, it appears as a local complication caused by the inflammation, pancreatic enzymes, and mass effect, leading to stasis, endothelial injury, and hypercoagulability. So it can lead to further complications such as portal hypertension, gastrointestinal bleeding, and mesenteric ischemia, which all contribute to significant mortality and morbidity of the patients. Diagnosis is based on imaging, as symptoms and lab values are non-specific. We know that it affects around 5 to 26% of patients. However, there is a notable gap in the literature regarding the exact pathophysiology and the natural course, especially the time course of SVT. So our aim was to address these gaps in the literature. So the clinical question is whether there is a difference in SVT prevalence in different patient groups by diagnosis timing and other clinically important AP disease characteristics. We use the COCOPOP framework to identify studies that report prevalence, SVT prevalence, with the context of imaging done in the early phase. And the population is, of course, patients with AP. And hypothesis is that there is a natural course to SVT development, and there are risk factors associated with its development. We specifically focus on the early phase, which constitutes the first 1 to 2 weeks after symptom onset. So using a systematic search, we have identified 12 studies, and 3 more were identified by citation chasing. So here are the results of the analysis. These 2 forest plots show a subgroup analysis of SVT prevalence in different patient groups, grouped by either symptom onset and hospital admission or hospital admission. On the left, you can see on the first group, in the 0 to 3 days after symptom onset, prevalence is around 6%, and it rises to 23% after 3 days. So this suggests that there is a time course to SVT development, and we see a rise in cases after 3 days. On the right, you can see that on hospital admission, 12% of patients are affected. This could be explained by the fact that most patients delay hospital admission by a couple of days. Relative to symptom onset. So we see a higher prevalence in this group. This number also increases after a couple of days to 17%. Next, we did an analysis, subgroup analysis according to AP disease etiology, and we see that alcohol-induced acute pancreatitis etiology was associated with the highest SVT prevalence, 31%, or nearly 1 in 3 patients are affected. Contrasting this, only 12% of patients with biliary etiology are affected. Next, we did a subgroup analysis for pancreatic necrosis, and we see a dose-dependent association. So rising necrosis proportions are associated with higher proportion of SVT. For no necrosis, there is 10% of patients affected. Necrosis is under 30%. We see that a quarter of patients are affected. And if necrosis is more than 30%, more than half of the patients are affected. So this was the first meta-analysis focusing on the SVT developmental dynamics, but we had some limitations. Most of the studies were retrospective by design, and there is some imprecision due to these studies having low patient numbers. So the conclusion is that a significant portion of AP patients, up to a quarter of them, are affected by SVT, and there is a natural course to AP development marked by a notable increase in crises 3 days after symptom onset. There are some risk factors associated with SVT development, such as pancreatic necrosis and alcohol-induced AP. Implications for practice are that anticoagulation is essential in AP therapy, and screening should become a routine, especially 3 days after symptom onset and in high-risk patients. Questions for research are that can SVT be prevented with timely anticoagulation, and what is the optimal strategy to do it? There are some important results with early heparin intervention. It has been shown to reduce mortality. So this manuscript was accepted for publication at the UEG journal. Regarding the second project, we would like to assess the impact of CT calculated body composition on the outcome of patients with AP. By 2035, a majority of the global population is projected to be overweight, and we know that BMI correlates with severity and mortality in many diseases, and even in acute pancreatitis. The cause might be that excess fat especially has been linked to increased mortality by all causes, and visceral adipose tissue especially is responsible for production of many inflammatory mediators. There has been some recent results that body fat, especially and fatty infiltration of the skeletal muscle, are associated with higher mortality from all causes. And we know that CT and MRI are much better methods to estimate the body fat content compared to BMI. And our aim was to assess this relationship. So the question is whether there is a significant association between these CT calculated body composition metrics and the outcome of patients with acute pancreatitis, and the population for this study will be the GULASH study participants. They had a CT on admission and on discharge, and we would like to link these metrics to their outcomes. The implication for this research is that predicting severity in acute pancreatitis is really a hard thing to do, and most algorithms use only BMI or don't use any factors of body composition, and by using these metrics, these algorithms would become much more accurate. So as I said, there are around 500 patients with CTs on admission and on discharge. These are downloaded, and right now we are calculating these metrics. So to summarize my presentation, I have 2 projects. The first one shows that there is a time course to SVT development in acute pancreatitis, and in the second one we aim to improve prognostics of acute pancreatitis. And I would like to end the presentation with a quote from Nelson Mandela: "It always seems impossible until it's done." Thank you.
Congratulations. May I ask a question about SVT, splenic vein thrombosis? Are there strict data about that? Is it an independent factor of the worst outcome, or it's just one sign?
So it has been shown to be present in patients with higher severity, and we know from other diseases that having SVT leads to complications otherwise, so we can only hypothesize that having SVT in acute pancreatitis leads to worse outcomes. So
no data about, a mortality or other severe outcomes?
So usually it is linked to worse outcomes, but independently it has been not shown to be a worsening factor.
You mentioned that it was more prevalent in alcohol-induced acute pancreatitis. Do you think that it might be the consequence that these acute pancreatitis are repeated events and they had a previous pancreatic injury, or was it strictly new cases? Were they only new cases selected?
We don't know exactly from the studies. They don't report this kind of data from them most of the time. What we hypothesized is that those patients with alcohol-induced acute pancreatitis have more necrosis usually, and necrosis is has a stronger correlation with SVT. So this might be the underlying cause for alcohol-induced patients having more SVT.
If it is the case, you would see higher frequency in hypertriglyceridemic pancreatitis because these are the really serious ones usually, but you had not much publication on that, I saw. Right?
We had 1 or 2 studies reporting hypertriglyceridemia, so it's quite rare.
I would like to ask a question regarding your second study. So I was wondering, how do you arrive at some kind of body fat measure based on the CT scan? So what's the method to get from the CT scan to some intermediate value that helps you predict AP outcomes? Thank you.
So we would like to use some artificial intelligence in this, as doing it manually would require many hours for just one patient. So some artificial intelligence would classify every pixel on the images as either fat, muscle, or other types of tissues. And these pixels are, so they are voxels, called voxels in CT, because they represent a volume depending on the pitch and the slice thickness. So from these volumes, we could estimate body composition regarding these tissues.
Thank you. And do you already have the AI model doing this, or is it something in the future?
So we are in talks with a company to do this.
Okay, thank you.
Do you know some factors that would influence the AI to actually have the correct voxels?
Factors such as?
I know, for example, in the heart, because I worked with similar programs, a stent can have an impact on the quality of the AIs.
Well, these do influence it, most likely, but over a large amount of patients, these small interferences might be negligible,
Thank you.
I would say.